Hi, Robin Lamar. I'm the chair of the Lactation Task Force, and I'm delighted to present Dr. Susan Crowe as our guest speaker this week for part of World Breastfeeding Month. Dr. Crowe is a professor of obstetrics at Stanford, and she has done a lot of work while at Stanford to support lactation, both within their own community through Stanford Well MD and Well PhD, that's leading efforts to support lactation and breastfeeding for individuals returning to work, both in the clinical and research environments, but also for patients delivering at Stanford. So with the birth experience there, the expectation being that dyads have the golden hour and support for breastfeeding in both vaginal and cesarean deliveries. She speaks widely on a variety of lactation-associated topics, which is what she's here to talk about today. I also have the distinct pleasure to announce that she's going to be doing a career change this year and will be joining our faculty here at UCSF starting in the fall, also in both OBGYN as well as in her capacity as someone who practices lactation medicine. So without further ado, I will turn the mic over to Susan.
Thank you. Thank you for that warm introduction. It is a privilege for me and an honor to be here to speak to you all. And this is a little bit different than some of the hands-on clinical work that I often speak to regarding lactation medicine. But I also think it's really an opportunity for us to discuss advocacy as at the local as well as national and global levels. In terms of disclosures, I'm going to reduce this. Here we go. Everyone can see me, I hope. Please let me know also if there are questions or things that come up during my talk because I may not be able to see the chat. In terms of disclosures, oh, I changed this slide here, but I wanted to let you know that today I will be discussing I'm sorry, I have, Patrick, I actually need to pull up a different, a set of slides. So I am going to stop sharing. And Patrick, I apologize, we practiced this ahead of time. And Patrick, are you able to pull up the slides here? Let me, apologies to everyone. I thought that first slide didn't look right. And
Do you want me to share the slides that you emailed me?
give me just 1 second.
Take your time,
And
Susan. We've all been
if
there.
I can't believe this many years into my Zoom experience all right, so advanced, share, and let's see here, cancel, advanced, share. So I may need you to do this because, Patrick, because now when I put advanced share, I'm not even seeing the option of sharing my slides. So I will ask you to please share
Okay,
my
give me
slides.
1 moment, no problem.
Okay, thank you. Oh, Patrick, I do think
Did
that
you get
I
it?
actually figured it out. Are you with me
Okay,
there?
yeah, go for it.
Okay, thank you. And there we go. Okay, so you can see what you need to see then?
Yes, we can see your
Okay.
screen. Looks perfect.
Thank you. Okay, so I do want to say, as an obstetrician, that I support breastfeeding policy and accommodations for lactating people, and that I acknowledge that this topic can be hard for those who have struggled to breastfeed when they wanted to those who are unable to become parents and wish to, or those who have experienced lactation without a live-born infant. And just want to acknowledge that as we may have different things that we think about as we hear about lactation topics. And I also want to create an inclusive environment with regards to language. Many people may prefer different terms: breastfeeding, chest feeding, breast milk, human milk. And as healthcare providers, we want to ensure that we use terminology that is preferred by our patients. I also approach lactation as being included along the spectrum of reproductive rights and inclusive in reproductive justice, and want to acknowledge the importance of including choice, both the choice to breastfeed and the choice not to breastfeed under circumstances that are specific to what only our patients can describe. In terms of learning objectives, I'm going to discuss some current lactation epidemiology and existing equity gaps, as well as how we can take action to support lactation and to celebrate our progress over the years. So here we have, I'll highlight that World Breastfeeding Week is something that we celebrate every year between August 1st and 7th. The theme this year is to prioritize breastfeeding and create sustainable support systems. In terms of the global, oh, wait, I wanted to pause that back there. In terms of global, the exclusive breastfeeding rate at 6 months in 2023 was 48%, close to the target of 50% in 2025. But there's a lot of action that still needs to take place in the arena of lactation globally and locally. We have in the United States, we celebrate National Breastfeeding Month in August, and it's divided up between these weeks. I'll highlight that there are both historical and current specific needs to communities who have been impacted regarding lactation barriers and support. The second week of August is Indigenous Milk Medicine Week. The third week of August, ANHPI. And as we look at the way we categorize lactation breastfeeding rates in the United States, that there are differences amongst various Asian communities in terms of the needs for lactation support. This week, we're celebrating Black Breastfeeding Week, and I'll say a word about that in a moment. And then we've added into September Workplace Lactation Week and Semana de la Lactancia Latina. So this week, as I mentioned, is Black Breastfeeding Week, and I'd like to point out and express gratitude to the women on these slides here who have really helped to establish Black Breastfeeding Week and addressing the needs in the Black communities. This theme this year is rooted in breastfeeding success, grounded in community support. So I'm going to give a little bit of background about the health impacts. And I prefer, as I talk about these things, to think about it in a global and national public health impact. I also, there's some variation in the way we talk about health benefits versus health risks. And in a society where I don't believe that we have fully supported lactation, that there are barriers that exist where not everyone can choose to follow these guidelines, excuse me, that I prefer to still look at it as, and to present it as, we have a lot of benefits and health advantages to breastfeeding. Others would say that I am using that the risk of not breastfeeding would be an alternative way to present it as we think more and more about lactation, breastfeeding being the norm for how we feed infants. So exclusive AAP changed their policy in 2022 to include recommendations for breastfeeding to continue exclusively for 6 months, followed by continued breastfeeding as complementary foods are introduced, with continuation of breastfeeding for 2 years or longer as mutually desired by mother and infant. Back in 1997, the AAP changed their recommendations from any breastfeeding at 6 months to any breastfeeding at 12 months. And then this has evolved over the years as we look more and more at health impacts as well as policy impacts. By increasing the recommendation for 2 years or longer, there are impacts on culture, policy, and now alignment with the World Health Organization and international organizations who have made these recommendations. I'm going to highlight just a couple of things. There are very few randomized controlled trials, as it has not been considered ethical to necessarily randomize people who are choosing to lactate and breastfeed, and to either breastfeeding or not. But I will talk here specifically. There was a landmark epidemiologic study back in the early 2000s that was published in Lancet that showed a decreased risk of breast cancer, relative risk decreased by 4.3% for every 12 months of lactation and breastfeeding. This was looked at a large number, more than 50,000 people who had lactated, and this was something that was at the time very revolutionary to see this kind of data published. And so then follow up, we've seen multiple other sources who have further reinforced this, with this below study demonstrating 12 months of lactation, 26% lower risk of breast cancer, ovarian cancer, 30% reduction in risk if ever breastfed compared to not breastfeeding, with a more profound impact, 37% lower for people who breastfed for more than 12 months compared to people who have not breastfed. And then globally, over 820,000 children's lives could be saved globally every year among children under 5 years. And if all children for the first 2 years were optimally breastfed, this was put out by World Health Organization and UNICEF. So what are the studies in terms of what is reported in the United States by the CDC? This was recently released at the end of July for infants born in 2022 in the United States. These numbers are not rapidly changing and have not changed much over the last couple of years. But overall, I want to celebrate some improvements and highlight some inequities that continue to exist. So overall, breastfeeding in the United States is initiation about 85%, in California 90%. Breastfeeding at 12 months overall is more than a third of our infants have been breastfed at 40% or higher in some communities. California also reflects more than 2/3, and these numbers are actually much higher than they were a couple of decades ago. In the year 2000, these rates were less than 10% and almost unheard of in medical communities. I want to highlight, however, that across the board, there are fewer Black infants who are experiencing the benefits of lactation, as well as the lactating people in Black communities. There are fewer of them experiencing the health advantages that we can offer through lactation. And when we look at these percentages, these are merely percentages, but they represent a large number of infants and parents who are lactating. From the global perspective, this has shown, I want to highlight the percent of babies under 6 months old who are exclusively breastfed has increased over the last 12 years. dramatically. There's been about a 10% increase. And the goal here is that we continue to direct until 2030 targets of 70% of exclusive breast milk feeding up to the age of 6 months. There are many efforts underway, but there is much work to be done, and I'll talk about some of that in a moment. In terms of how are we doing locally at UCSF, these numbers are actually very similar to what we see at other, certainly at Stanford and other academic institutions. I do want to highlight, as we look at UCSF exclusive human milk feeding, there is the privilege and opportunity to provide donor milk from our pasteurized donor milk that has been donated and provided by milk banks. And this contributes to these exclusive human milk feeding rates. And I'll highlight this. So in calendar year 2024, overall, there's a close to 80% of exclusive breast milk feeding rate, and about 15% of those infants did receive donor breast milk during their hospital stay, so about 64% of parents' own milk. In the 2025 through May data, those numbers are similar, about 76% of infants who are, and these are well babies, not NICU infants. The donor rate, so about 76%, the donor rate, the rate of babies receiving donor milk is about 21%, so about 54% of parents' own milk. And this is not, when we think about supplementation in the first few days of life, nationally, we've seen an increase in supplementation rates, primarily using formula. In 2015, about 17% of babies received formula in the first 48 hours. And in 2022, that number increased to about 23%. And so just something to think about, not clear what the etiology, why do so many of our infants receive supplementation in that first couple of days? And if they are medical, why are so many needing medically indicated supplementation? This is certainly something I don't have the answers to, but important topics for future considerations. We also at UCSF look at exclusive human milk feeding per payment mode, as in for Medi-Cal patients. And we do see that the rates of exclusive breast milk feeding are in the 50s and not in the high 70s, as we see across the board. And that's something that we also want to continue to think about. At Stanford, we've looked at data regarding race, ethnicity, and even language preference, and we've found that there have been lower rates of exclusive breast milk feeding, specifically amongst our Spanish-speaking or Spanish-preferring patients, and wanting to look into that and see how we can approach that to improve that. And we've addressed that also when it comes to the acceptance of using donor milk in lieu of formula when supplementation is medically indicated. Here we see by race, ethnicity, the exclusive human milk feeding rates also demonstrate disparities between different groups. And in this, the way that they are collected, I'm not sure what goes into this group of other, but it certainly seems to be a high rate of exclusive breast milk feeding amongst them. I'm not sure if how to categorize that group. So I want to talk, I'm not going to go through all 10 steps to successful breastfeeding that have been established really by the World Health Organization and UNICEF, but I do want to go over some of the updates. And in terms of updates that we have emphasized over probably been about 5 years now, there has been a new focus on complying fully with the International Code of Marketing of Breast Milk Substitutes. I'll mention a little bit more about what that entails. And then there's also been further focus on facilitating immediate and uninterrupted skin-to-skin contact and support to support mothers to initiate breastfeeding as soon as possible after birth. I'll talk about those two things. I know that you are all very likely familiar with these 10 steps, but I did want to emphasize that these 2 steps have been updated and there are further emphases being placed on those 2 steps. We also know that as people experience the breastfeeding friendly, the baby friendly, not my choice of words, but the baby friendly, I really see this more as family friendly steps to increasing breastfeeding success. We can see dramatic differences in exclusive breastfeeding at 3 months. And we know that there are a lot of things that babies benefit from in terms of skin-to-skin care at birth. So over the decades that I've been in practice, we've seen a dramatic increase in skin-to-skin contact and rooming in during my time in practice. In 2007, 40% of after vaginal birth, 40% of infants experienced skin-to-skin contact, and I certainly wasn't one of them who ever really saw this until after 2011, when more than 50% were receiving skin-to-skin contact care. And then in 2015, at vaginal birth, 83% of infants were experiencing this. And the rooming in is also increased. The point of rooming in is really more related to having access to watching feeding cues and to being able to bring in a full milk supply by feeding whenever an infant shows feeding cues. So skin to skin at birth is on the left here. I'm sure that you all have seen this, but I highlight this because for many decades, really what we saw was if a little bit of skin touched a little bit of the mom, that we thought that was skin to skin. I'd like to point out that probably around 20 to 25% of our infants born to first-time parents are born by C-section. And then due to repeat C-sections and other indications for C-sections, certainly more than 30% of our infants are born by C-section. So looking at those numbers, we don't want to leave those infants out of the opportunities to benefit from skin to skin at birth. And it also, by allowing this, by facilitating this, we increase the choice options for our parents who may want to lactate and breastfeed, such that I will just briefly tell one story. I had a patient we were about to do a C-section on, and she indicated that she didn't want to breastfeed. She was diabetic. She had a lot of health advantages to gain if she were able to breastfeed, but she had tried with her first 2. It didn't go well, and she didn't want to do that. So I asked her, I was able to later in the surgery come over to her side and ask her if she'd like for me to help her just have her baby right next to her. So I held her baby right next to her, and she had been able to experience some skin to skin, and her baby latched on, just showed signs. I asked her if it was okay. So she had her baby latch on, and she indicated that, well, actually, she did want to breastfeed. Neither of her other 2 who were born by C-section had ever latched on, and she hadn't found the experience of pumping and expressing milk to work for her. And she went on to breastfeed for At 6 weeks, she was breastfeeding for exclusively and had had a completely different experience. So when we think about choice, we think about what choices are we really presenting to our patients and families, and wanting them to experience the full range of choices that would allow them to make the choices that are best for their families and really open up what choices they see before them. There's growing evidence about skin to skin, which makes sense. We think about postpartum hemorrhage prevention. We know that by having an infant skin to skin, even that alone without lactation increases oxytocin. And we certainly know that oxytocin is associated with decreased hemorrhage. So these are all things for us to think about as we continue to move forward with having skin to skin be routine, both at vaginal birth, but at C-section as well. I'm going to take a moment to talk about how to support the choices of our patients who have suffered from pregnancy loss and experienced abortion, in particularly the second and third trimesters. So this is a qualitative study that looked at the feedback from people who had been through these losses, and it looked at interviewed people who had had abortion or stillbirth from between 16 and 40 weeks of gestational age. And I won't read through all of these things, but I do want to highlight a person here. It was not only the physical pain that bothered me, feeling pain in my breast and knowing that there was milk and having no child to feed was agonizing. Here is another highlight. My heart ached as I woke every 2 hours with breasts engorged with milk and no baby to drink it. I realized my milk was going to come in whether I wanted it or not. And to really recognize the pain and agony and the need for us to support our patients who have gone through the losses, either through abortion, medical indications for termination, or late stillbirth. This is something that we want to think about. So we want to offer them options. Milk expression can be something very important to people. The process of donating milk was, or actually of expressing milk, was almost meditative. It was a time that I could relax and think about Archie, our son. This can be something that's very important to people, to know that they are contributing to the availability of human milk and banked milk for our most vulnerable infants. Some have chosen to make breast milk jewelry as a keepsake and remembrance of the loss. There are also supportive measures, although I will highlight that these supportive measures may or may not actually offer an intervention to decrease the experience of pain and other symptoms related to milk engorgement, as well as any milk coming in. So I want to highlight that we do have an option now of cabergoline for lactation inhibition after second trimester abortion or pregnancy loss. And this is something we're all more quickly adapting to research done at our own institutions, and would like to point out that Dr. Andrea Henkel has done a lot of work in this arena, and that we are adopting pretty universally at Stanford if people choose not to experience lactation symptoms. Cabergoline 1 milligram orally within 4 hours of fetal expulsion or procedure. With these contraindications, this dosing was found to be optimal. I will say that it is very hard to, in rare cases, there are people who may have been misdirected at, and for example, I've had some patients who have breast cancer diagnoses during pregnancy who have chosen to utilize this but who also we want to counsel about the options fully, because this is very hard to reverse. So if people hear the options, they may choose actually to lactate and breastfeed for a short duration of time, which, given the cabergoline and the effectiveness, may be very difficult. I'm going to now briefly give some background about maternity care and the International Code of Marketing of breast milk substitutes, so that we can understand a little bit of where our advocacy needs to go. So in the early 1900s, most births were at home, but as we transitioned through the 1930s, 50s, and then eventually to the 70s, where 99% of births were in the hospitals, formula marketing was also taking off during this time. It was initially formula developed to help infants who had no access to the milk of their parents. Some of their parents had died during childbirth, but today it's grown into a multi-billion-dollar industry. These were advertisements that were given to parents during these times, that that they should not attempt to breastfeed, that their infant would be just as healthy, sometimes more healthy. There was also formula samples given to people, and then until their milk supply decreased, and then the formula samples were no longer given, leading to global impacts on infant mortality in tragic ways. So there were a lot of reasons that the code was established in 1981 by World Health Organization and UNICEF, recommending practices against unethical marketing of formula. So we've seen here that in spite of clear messages on the importance of lactation, global sales of breast milk substitutes continue to grow and went from 44.8 billion US dollars to 87.4 billion US dollars in 2024, and with continued anticipation growth of at least 10% per year. And the code addresses free samples, promotion in the healthcare system, gifts to healthcare workers, as well as not having donations of infant formula given to the healthcare system. It addresses labeling of formula, as well as I want to highlight that newer updates of the code discuss no sponsorship of meetings of healthcare professionals and scientific meetings, as well as addressing the targeted population of toddler milk from 1 to 2 years. And so those two of the code that have been updated. Regardless, we still see high rates of sponsorship of infant formula companies as we attend professional conferences. And we found that people who are exposed, countries who utilize implementation aligned with the code, have much higher rates of breastfeeding and lactation beyond into the 20 to 23-month-old range, whereas in the US, there are no legal measures to protect and advance the code of marketing, and that many countries such as us have lower rates of lactation that continue into that time frame. So what can we do? We can document the problem. And I'm not sure this here, I want to credit you. I meant to credit that earlier. The U.S. Breastfeeding Committee has done enormous work nationally and likely internationally to facilitate the advocacy so that all of our parents receive accurate information and support in lactation. And the U.S. Breastfeeding Committee has helped with the provision of these slides. I think that we look at what we can do also in the hospital settings. We may see things inadvertently. Our media, public relations people about a decade ago were celebrating our wonderful nurses and the care they provide on the maternity unit, but they inadvertently put a life-size poster of someone feeding a certain brand name of infant formula that we use at Stanford. And it was helpful to just highlight and say, hey, we aren't wanting to promote this as a norm for feeding. And it was immediately changed. So we don't necessarily need to publicize it, but highlighting these issues that come up at our hospitals and in our communities. Now, there are more and more people exposed to advertising through social media, and that's also something that we need to address. We also want to advocate for restrictions on commercial milk formula marketing in the US and abroad because of that tremendous impact. I won't go through all this legislation, but I do want to celebrate that lactation and breastfeeding has become exempt in our states so that people can breastfeed. This was not a given years back. We also want to celebrate lactation accommodations in the Affordable Care Act. Lactation accommodations were put into place for our hourly wage earners. And then the Babes Act is another, and it's being updated because there are further gaps that have been made visible by the Babes Act, but that people could go through TSA checkpoints. The federal legislation more recently, the Pump Act, was implemented to close the gap so that salaried workers could also participate and benefit from legislation that protects them in the workplace to have time and space to express milk. The Pregnancy Workers Fairness Act, it was also implemented, providing for workplace accommodations that would extend into the postpartum for lactation, also reinforcing the importance of pump breaks and giving access to a location. And I do want to say that it clarifies, the Pump Act clarifies that pumping time counts as time worked if people continue to work during the time that they're expressing milk. These things may seem obvious, but many people across our country, across the US, as well as across the world, have experienced difficulties in these arenas. California has been instrumental in providing a role model for the country, as well as implementing protections for people who are vulnerable populations. For example, in 2020, incarcerated people in county jails have the right to express milk. There are also expansions where people can provide that milk to their infants. Perhaps what I would prefer to see is that incarcerated people have the right to access their infant for lactation. This is something that's been experimented with in a couple of other states, but I see as something, a real opportunity for the future. I do want to also point out that California is one of the states providing paid family leave that can orchestrate an environment where people are able to establish lactation and be away from work while they do that. It's a much easier environment for people to establish lactation when they have not returned to work, in spite of the accommodations that we can now provide. California paid family leave has expanded over the years since it's been established and provides 70 to 90% of salary for up to 8 weeks. And the previous waiting period has been removed. It also went from 6 to 8 weeks, and more information can be given. I want on the EDD website. I do want to highlight that people who pay into state disability also pay into a fund that pays for paid family leave. This fund is growing because people aren't always aware that they can utilize this fund. And so it's not, people pay into it, and that fund pays people during paid family leave. So they can extend beyond the disability that California also provides for 6 to 8 weeks postpartum routinely. An additional 8 weeks of pay can be added. This is really important. It's an underutilized fund, and we want people to take advantage or to make the most of this opportunity. Mapping paid leave. We are one of the few countries in the world who do not provide a national level paid family leave, and this is an incredible opportunity for us. When one looks at the future of formula feeding, the formula companies see this as a tremendous opportunity for them as they see people who return to work have more challenges in maintaining lactation. And this is an opportunity for us to take that, to reverse that, and to really implement paid maternity leave, paid family leave on a broader basis, and to be consistent with what we see going on globally. So I have only left 5 minutes for questions, but I welcome them, and I am not sure I can see the chat. Robin, do you want to direct me from the question standpoint?
Absolutely. Although so far there's just lots of welcome Susans and lots of enthusiasm for the talk and some of the stories you shared.
Oh, thank you. Thank you all. Oh, it's so nice to see um, some wonderful, I do see this now. Thank you so much. It's wonderful to see some familiar names, and I look forward to working more closely with all of you. And I just really want to thank you for that. Are there any other questions?
Hi, I have a question.
Yeah.
This was a really great talk. Thank you so much. And I'm excited to work with you. I'm Melissa Rosenstein, one of the MFMs. I'm just curious. I was struck by the number of infants that are being supplemented, right? And I recognize that human, donor milk is often offered, and we have that. And I'm just curious in terms of like the background, right? Like exclusive breastfeeding. Sometimes I feel like I'm kind of crazy. Like exclusive breastfeeding includes donor milk, which just feels like not the word, the, the meaning of the word, especially when we think about the impact on the actual dyad, including the parent. And so just curious, as I know that the benefits for preterm birth, like there's many documented benefits, but in terms of benefits to healthy term infants and the healthy term infant dyad, is this where we should be spending our efforts, and is there any is there behind the scenes in terms of the metrics which we can look at a metric of exclusive breastfeeding, knowing that 20% of them have received donor milk? Is that really, is there a way that metric will be changing? Is it really reflecting the true benefits that we think that we're getting?
I've had these same questions, and we need more research data to help us understand why we have such high supplementation rates in the first 48 hours. And my concern with that high rate of supplementation relates to, are we undermining confidence? Is there truly medical indication for so much supplementation? Or is there perhaps true medical indication? Are our obstetric practices, our obstetric populations, is there something that contributes to that we don't fully understand? And I don't have the answers to that, but I so appreciate the questions because I have them too. And it's going to be very important for us to shed light on those questions as we move forward. I do want to highlight that one thing that just intuitively is better about supplementation with the donor milk there's all sorts of reasons for the preterm population, but for the term population, donor milk supplementation will be more easily digested and not turn off the infant feeding cues for as long as 3 to 4 hours that formula supplementation would do. So there is also the messaging that's sent that says human milk is so important that people have donated it and we are bringing it to you. So there's those two advantages inherently that may be taking place, but I completely, I share your questions and I hope to bring more answers to that.
Thank you.
Thank you.
I think we need to have more anticipatory guidance, I think, for our patients if those rates are as high as they are, so that people can expect that they might be offered this.
Or will early milk expression there's so many other opportunities potentially that we can point people towards to help decrease those rates of supplementation. But yeah. Well, I do want to thank you all for your attention and your interest in my favorite topic. I hope to come back and be able to talk about some other clinical things that impact us. And I just will leave you all with a parting story. One night I was in the middle of the night called to do a stat C-section. Person was hemorrhaging. She was in like 34 weeks. She didn't have her family around. I'd never met her. Immediately, we deliver her. We save her life. We are able to do these things in these amazing facilities where we work that support us in that. And I went to check on her a couple hours later. And she introduced me. I was able to help her hand express milk, colostrum, bring it to her baby. And I went back to check on her as someone who had had quite a bit of bleeding during the birth and who had never met before. And her family was at her bedside, and she introduced me as the person who helped her get milk for her baby. And not in my mind thinking that I had provided this life-saving care for her. People don't forget the support that we offer them during this time in their lives. Their infants are of paramount importance to them. And I just want to thank you for all for being a part of that. And I know that people appreciate the work that you're already doing. And thank you for all of that.